Maria Leptin, ladies and gentlemen, and friends, I will start to give an introduction regarding the present most urgent problems regarding the cancer disease. I need this one to, very good, thank you. We have some main challenges regarding the increasing cancer problem. We have about 20 million new cases globally and 10 million deaths due to cancer. We need to decrease the incidence, that is obvious. We need to increase the cure rate, that is also obvious. What is not as obvious is to improve survival, but we said when we cannot cure patients, we should try to improve survival, and that is good into certain limits. An important further concept is improve health-related quality of life. That has been more and more visible, and we understand it with such a large proportion of the patients suffering from cancer disease before they die. Incidence may significantly reduce by prevention. And here people are working with identification of causes of cancer, like genetic, lifestyle, environmental factors, etc. Implementation of present evidence-based knowledge may decrease the cancer problem with about 50%. That is what Chris Wilde said a few years ago when he initiated the establishment of the European Prevention Consortium. And using research, we can raise this question. We heard about HPV vaccination, and that is a success story regarding cervical cancer. No doubt about it. We heard about population-based screening for early detections. Here it is a problem because it gives rise to early detection of invasive cancer and also precursor lesions. Prevention by early detection should focus on precursor lesions, but it's important also to identify early cancer. But then we should need which cancers are disseminated from the beginning so we can treat at an early stage of the disease. That is a missing element. Increase of the cure rate is a very complex challenge. Here are just a few thoughts about it. We need strategies to solve the problem with the genomic instability of cancer cells. We need new types of targets for treatments. We should use combination of targeted anti-cancer agents and explore this area, and that is not done very much, I must say. What is an interesting development is immune oncology, where we can see interesting progress. We need to go to treatment at an early stage of the disease, early detection of metastatic disease. All technologies, all biological materials are there, but we don't do it very quickly, I must say. We need to identify reasons for failing treatment by reverse translational research. Technologies are there, materials are there, but we are not very much focused on that area. Improvement of survival of patients with incurable disease. The problem here is it converts cancer to a chronic disease, which is a main problem for the future. And we see trends already about it. If we go to incurable leukoregional disease, of course, radiation therapy has a very important mention here, and there are good possibilities to increase that. Regarding systemic treatment of patients with disseminated incurable disease, and this is a huge population of patients, if you understand that 10 million deaths every year. Here we test new anti-cancer agents, immunotherapy. What we are not doing very well is the adaptive treatment methodology that should be tested more in detail. But this is a very difficult area. And the goal should be to decrease this patient population as much as possible. And you can do it by increasing the cure rate, and you can do it above all by prevention. Health-related quality of life research needs more visibility and support. And we are happy in Europe that European Commission have seen this problem and push for it. But this is a big area for translational research. In the supportive care area, psycho-oncology, rehabilitation is not developed very well in many countries. Early palliative care, incurable disease with possibility to prolong survival. We need to see what is palliative care. Palliative care starts the day when a patient has incurable disease. And then we try to prolong survival. But you see, health-related quality of life is a very, very important part of the care. And also for the late palliative care, when we should avoid anti-tumor treatments. And increasing problem is survivorship. Increasing number of patients with long-term side effects. We don't care very much about it. And also patients with chronic cancer disease. One should try to move from the thinking to convert cancer to a chronic disease and go much more focused on acute disease. What we need to do it is, as I said, translational research. We define translational research in this way as a coherent research continuum that starts with basic research in cancer biology, moves into preclinical research, later into early clinical research, and further into clinical research with the aim to implement innovations in the healthcare system. With further follow-up of outcomes of innovations, and we need the real-world data to do it, and that involves, of course, also the quality of care. We need long-term follow-up of cancer. And if we look at this research continuum, and we'll come back and discuss missing elements in the translational research, we can see that the missing elements start in the area of clinical research before the implementation of the research. So here we have a lesson to learn. By definition, we see also that translational research is bi-directional, and we do use it enough. We have a similar research continuum also for prevention. I don't go into detail, but it's built on the same principle. And it's important to say again and again, the basic research, preclinical research, is fundamental because it sets the agenda for the translational research. And in the previous conference we had a whole session discussing the interaction between clinical researchers and basic researchers in order to support the development of the preclinical research. Yeah, then we have a semantic or linguistic problem, and that is we started to use personalized medicine when De Hood for more than 15 years said that we should have P4 cancer medicine being predictive, preventive, personalized, and participatory. For some reason, everyone went over to precision cancer medicine, which is a very vague objective. We don't understand what is precision. So I would say we have to go back to the Hood's suggestion here. Make cancer medicine predictive, preventive, personalized, and participatory. That is also a very important part. And I'm very happy that Lee is willing to come here and tell us about his view about this. BASIC is a concept of a comprehensive cancer center because we need multidisciplinary cancer care in order to keep up with quality. And that means that we need all the components for cancer therapeutics care. In the center, we need also the health-related cancer prevention part. We need that integrated with research and with education. And if you can read the box at the right, the CCC with integrated basic preclinical research is fundamental, a fundamental infrastructure for translational cancer research. We need to see that clearly. Without the comprehensive cancer centers, it will not be possible to establish a complete translational cancer research. Well, something has happened here. You understand this machine? In that direction. Okay. Okay. I try to do it. We have two fundamental objectives here. That is to decrease inequalities, and inequalities are, they are very, very important, especially if you go globally between countries, but you have it also within countries. And the other is innovation. But if we look at the inequality problem, we need the multidisciplinary high-quality treatment and care. But it has to be continuously innovated. Otherwise, it's not of high quality in very few years. For that, we need quality-assured CCCs. And an important question is how to quality-assure CCCs, and how should we look upon when we need CCCs of very high quality or high capacity to innovate research, CCCs of excellence. We'll have a specific session on that and discuss that more in details. And that relates also to the fact that a majority of patients are not living in the catchment area of a CCC. We made a rough calculation in countries with large amounts of CCCs, and about 80% are outside the CCCs. And with increasing needs of technological resources, both for treatment or research, that will increase inequalities over time. So I would say one of the very, very important questions if we talk about inequalities will be how to offer all patients high-quality, innovative cancer treatment and care. Yeah, now it works. We need also the complete translational research continuum. And I bring up a few areas where we have suboptimal or missing elements in the research continuum. Overall, prevention research is not covered in the way it should be. It has at present about 10% of the total funding for cancer research. And this is a big mistake. Preclinical and early clinical research, we talked about this, is very important. Structuring prevention and clinical trials for implementation is very important because this part of the continuum is not completely structured. Health-related quality of life research is missing in most areas. Outcomes research is almost not existing, as is not health economics research. So we'll point on that very much in this conference and look upon what should be done in order to involve health-related quality of life, outcomes research, health economics research. Increasing costs for cancer therapeutics care is a big problem. We have an increasing number of new anti-cancer agents accepted by the FDA and EMA on a fast track since about 25 years. And fast track means that they are accepted with less information than we usually wanted in order to talk about evidence-based medicine. They are mainly used for treatment of patients with incurable disseminated disease, demanding for early palliative care. This is another big problem. So we have a huge number of patients here. And we have two main problems we need to discuss. Huge costs for the healthcare, and that has been analyzed, and we will listen to that. Since treatment outcomes are poorly evidence-based, this is also an ethical problem. So I hope it's good to discuss this within the Vatican city, the Catholic Church. The critical mass is another fundamental problem. Cancer biology identifies increasing diagnosis subgroups with variable clinical consequences. The patient population is highly variable: genetic background, age, additional diseases, frailty, etc. Development of complex technologies for stratification of patients is increasing in order, but you have it in only selected centers, so you need collaboration between centers. No single CCC has the critical mass of patients and biological specimens for innovative translational cancer research. So the solution must be national and international collaboration between comprehensive cancer centers. Funding mechanisms are not adapted to the research we want or the research European Commission wants, the research you want from NIH. So they are not adapted to the goals, and that relates both to translational research and relevant infrastructures. Here, US is a little bit better than we are on infrastructures. Main funding of cancer research is provided by for-profit organizations, mainly the pharmaceutical industries. We will listen to a deep analysis of this. So the conclusion is, increase not-for-profit funding. Academic centers should set the agenda for the translational research. I think that is very important, because this is not the case today, and we will hear more about it. So a long-term goal for translational research is to increase innovation and decrease inequalities, and well-organized, that can be done in parallel. Establish evidence-based cancer prevention and therapeutics care. Establish structures for outcomes research in terms of clinical effectiveness. Effectiveness, not only efficacy, effectiveness. Involve health economics research and assess cost effectiveness. Increase of national and international collaboration with comprehensive cancer centers and sharing of resources will increase innovation and decrease inequalities. That is the main point. Education, of course, is a big challenge here. Thank you.